Good morning, everyone, and thank you for attending today. I want to start by thanking my panelists. I want to thank the Reagan Foundation for this terrific event. This is my first one, and I can see now why everyone talks about this as really the premier national defense and national security event. I want to thank Roger Zakheim in particular for inviting me to participate in this, and I'd also like to recognize a special guest. Gary Sinise is here. Gary? Is Gary in the room? Was told that Gary was going to stop by and be a part of this panel. He does terrific work for our veterans, for service members through his foundation, and so appreciate his support as well. I'd like to take a minute and introduce the folks on the panel. Senator Moran was supposed to join us. He was obviously a little bit busy in Washington last night, and so he could not be with us. But directly to my right is Congressman Brad Wenstrup. He represents the 2nd Congressional District in Ohio. He's chairman of the House Veterans Affairs Health Subcommittee, member of the Armed Services Committee. Dr. Wenstrup is a colonel in the Army Reserve, and his reserve duties include treating patients at Walter Reed. Vice Admiral Raquel Bono, director of the Defense Health Agency, is a surgeon and actually just a moment ago threatened me with disembowelment. I'm not sure.
It was merely a suggestion. It was merely a suggestion.
So, well,
it was a clinical recommendation.
Well, that puts my mind at such great ease then, Admiral. I appreciate that. Her career in the military medical field includes assignments as a surgeon, which means she's qualified to do what she suggested that I need. Overseeing casualty receiving and burn unit care, and has also served as director of the National Capital Region Medical Directorate of the DHA and chief of the Navy Medical Corps. Dr. Dov Zakheim, senior advisor at the Center for Strategic and International Studies, Undersecretary of Defense Comptroller and Chief Financial Officer at DOD from 2001 to 2004. I met him when he was a member of the Commission on Wartime Contracting in Iraq and Afghanistan, and he's also served as a member of the Military Compensation and Retirement Commission. And finally,
I just want to say this because I overheard that conversation.
Yeah.
And
here we go.
One of the things the Admiral said was, "This will be painless." And I thought to myself, I should have told people that when I was cutting their budgets.
You should have had the Admiral's help maybe to do that as well. Right. Farthest to my right is Orie Mullen, who has not threatened me with any medical procedures. He is president of Humana. I'm sorry?
Not qualified.
Well, but you know people.
Yes.
As president of Humana Military Healthcare Services Incorporated, he manages the Defense Department TRICARE South contract. His first assignment, military health, for the company was in 1999. He's been with Humana since 1986. So we have a cohort of people here who obviously know what they're talking about when it comes to the military health system. Admiral, I'd like to start with you, please, and just outline what the evolution of the Defense Health Agency has been over the last several years since Congressman Wenstrup and his colleagues first conceived of the idea and you began to execute.
Great, thank you, Francis. And I'd like to echo my own appreciation for being invited here and having an opportunity to participate in the conversation, and more importantly, hear some of the conversation by our thought leaders in industry and in government and across the sectors. So I think to start answering that, what I'd like to do is thank Congress for being able to give us the latitude to actually stand up the Defense Health Agency. And I really think through the lens that I've learned here in the Reagan National Defense Forum is that this is a fairly significant effort to help bring military health into part of that security strategy talk. Because part of what we do in the defense health system and what we do with military health is we make sure that we take care of our active duty and our retirees as well as their family members to make sure that they're always at the peak of their performance. And the Defense Health Agency allows us to do that in a way that's very contemporary, that's leading edge, and then allows us to participate with industry and others to create that type of product. So through the Defense Health Agency, we've been able to take a very strategic approach to how we deliver that health care. It's very easy to see the military health system in an operational setting because you see us go downrange and respond at a moment's call. And like General Goldfein said, is that we're prepared to go forward whenever that call goes up. But more importantly, with the Defense Health Agency, we have an opportunity here now to work more closely with industry to find out what some of those best practices are that we can bring into our military health system to make them more modern, more contemporary, and more relevant. We also have the opportunity of being very aggressive and very forward-leaning in the way we procure our medical services and being able to do that in a way that's competitive and allows us to choose the highest level of care that's available out there. And then if I look at what Secretary Mattis is asking us to do in terms of reforming and rebuilding, then what the Defense Health Agency allows us to do is create those efficiencies, find those savings so that we can not only recapitalize and reinvest in our own military modernization, but it gives us also the working capital to modernize our own military health system, recognizing how rapidly the technology of healthcare is changing and how imperative it is for our own national security to be at that edge of innovation and being able to offer the men and women in our services that level of healthcare. So I think the Defense Health Agency, since our startup, again, through DepSecDef and Congress, has been very generous and very supportive in us evolving to this type of entity. So very much appreciate what we have and what we have the ability to do now. Thank you.
Thank you very much, Admiral. Congressman, what do you see? So you have two different perspectives on this. You see it as a care provider, and you also see it as an overseer watching what people like the Admiral are doing. What do you see from each of those perspectives?
Well, it has been an interesting ride for me as I am still in the reserve, and I spent a year in Iraq, so I was downrange. Before that, I did spend time in garrison, in our facilities, at our Army posts, taking care of patients. And our challenge has been since the beginning of time to not only be a medically ready force, but a ready medical force. And in addition to that, we take on the responsibility and provide the benefit, the deserved benefit, to not only take care of our troops downrange, take care of them at home to make sure that they're ready to go downrange when the call comes up, but also to take care of their families and to take care of retirees. And so from the standpoint of being involved with industry, that being the rest of the medical world within our country, this is a needed thing, and this is an important thing to allow us to do that. Now, I sit on the reserve side mostly, and I take a concern all the time of, are our reservists always ready? But also, are our active duty always ready? And I know Admiral Ono and I have talked about it, the challenges that we face, especially in downtime, when we aren't as busy, say, with wounded. How are we keeping everyone operationally ready? And the challenges that we face. We're starting to see more interaction with civilian centers for all types of training, not just level 1 trauma surgery, but even down to the lower MOSs, military occupational specialties, OR techs, lab techs, radiology techs, things like that. We're seeing more interaction. So just as anyone in the military, for caregivers, you need those repetitions. You need those repetitions. So we're trying to provide a lot, have a ready reserve, have a ready active duty, provide for families, provide for retirees, and that's a lot to bring together and to keep up with everything that's changing in medicine and to get those repetitions for our providers.
Is that reps problem then, it sounds like that's the same problem General Goldfein talked about on this stage in the last panel for pilots and people performing service on the aircraft and everything. Is it the same thing, same idea?
Oh, it definitely is, and you get better. You ask any surgeon, were you faster?
I was merely looking for practice when I made that.
Yeah, just looking for reps.
That's right.
Reps.
Great.
That's right. But I'm sure, were you faster 10 years into your practice than you were when you first started? And what brought that about? Your repetitions, your confidence, your abilities. You can only do so much on a mannequin, right? And so we need to be engaged in every aspect.
Dov Zakheim, I mentioned you were a member of the Military Comp and Retirement Commission. What's your sense when you look at what Admiral Bono's doing of what the military health system is delivering vis-a-vis what all of the people that you went out and talked to, and you talked to thousands of them, said they wanted and needed from the military health system? Are they getting a benefit that they think is worthy of the sacrifice?
Up to a point, I think they've definitely made progress. But there's a long way to go. And I think the Congressman put it very well. Admiral and your team, you're trying to do an awful lot, having just stood up a new agency. But there are some things that are really urgent, and I think the Congressman outlined those. The fact of the matter is that our surgeons in military treatment facilities are simply not getting enough experience. And the experience they do have atrophies very quickly. And there are numbers to back that up. In the civilian world, it's 500 a year. In the military world, it's about 100 a year. And the other thing, of course, is what surgeries are we talking about? When we looked at the situation in MTFs, we found that the #1 procedure was obstetric. 2.5 years later, the #1 procedure is obstetric. Now I gotta ask you, if you were, God forbid, involved in some major tragedy in this country, and would you want to go to somebody who helps women give birth to babies? You would want to go to the admiral who would take care of you without your feeling it.
Oh, she'll take care of me.
Yeah.
True.
Yeah.
Because she's had a lot of practice, and because she's practiced on the right things. So this is a very, very serious matter. Another issue that we raised, getting the surgeons out there. There's a thing called the magic hour. If you can get to somebody who can be saved in the first 59 minutes, correct me if I'm wrong, in the first 59 minutes, you have a 50% or so chance of saving that person. But if you got to them in the first 23 minutes, you have a 95% chance of saving that person. That hasn't happened yet. I'll give you another one, and then I'll stop, because we had a lot of recommendations. We still do not train in teams. We need to. We need our corpsmen, we need our enlisteds to be absolutely up to speed with the surgeons, because they operate as teams. There are only 2 places in this country where the surgeons right now train in a hospital. Cook County is one of them. That's just not good enough. And somebody asked me, well, what's the budgetary cost of this? Because after all, I used to hand out billions. And my answer is very simple. What's the budgetary cost of saving somebody's life? Of increasing the percentage from 50 to 95, over and over and over again. And by the way, the costs aren't that great either.
Congressman and Admiral, I want to give you a chance to follow up, because I both saw you nodding as Dove was
Yes.
talking. But Orie, I want to bring you in, and because I imagine.
Thank you, sir.
Well, you have a terrific perspective on the opportunities that Admiral Bono talked about interacting with industry, and I imagine not only are there things that you can teach her, but I think there are things that they can teach, that she and her colleagues can teach you about providing care in the private sector too.
Absolutely, and let me start by saying thank you to the Foundation for giving us the opportunity to be here. It's such an honor and a privilege to be here to hear the dialogue around all the activities going around national security, so thank you for the opportunity. You may not know who Humana Military is. We're a wholly owned subsidiary of Humana, one of the big HMA players in the country, top 50 on the magazine. So we're a wholly owned subsidiary. We're kind of isolated because our business is so unique, but it gives us the access to knowledge and understanding and learnings, because our parent company does Medicare Advantage, does commercial work, does Medicaid work, and does all the other stuff that goes on in the community. So it gives us a good laboratory to understand the best practices and then how to bring them to the MHS. This is beginning our 3rd decade of service with the MHS, and we're so proud to do this work. But being able to understand the systems that are built to take care of our active duty, our family members, retirees, and even veterans. When you think about the MHS as one lane, when you think about the VA, it's a different lane. And there's a CMS component into this care thing, and they're all managed this way, right? The patients look at it this way. And where's the opportunity up for us in the panel just before? So you talked about interoperability, you talk about sharing data, you think about making the care experience much better. You know, those are things that we need to bring forward to really put the beneficiary lens on and simplify this access to care. Because when you think about the rules that are aligned with each one of these systems, they're complicated as it relates to eligibility. It's very complicated around medical policy, and it's very complicated about scope of care. And so there are just tremendous assets in each one of these lanes. How do we maximize those assets and capabilities and really not do all this duplicative work that's potentially going on in all three lanes? And how do we make that experience better for, you know, for our military families and veterans and so forth? It's just, I think it's a great opportunity for us to talk about sharing and interoperability and really think about how's this stuff funded and how can it be done differently? So,
Congressman, anything that you heard Dove or Orie say that you
Yeah.
can comment on?
I would, you know, it's interesting. During World War II, I know in Cincinnati, University Hospital was a reserve hospital, if you will. It was called General Hospital, and there were several throughout the country. And so that hospital, you're talking about teams, that hospital got called up as a team to go to war. They had to go to war mission. And so that is something that we don't do as well as we should, is to train together as teams, unless we have adequate time before we go to really put that team together. But on a moment's notice, we're not always there. You know, we have accomplished so much in the last 16 years. A friend of mine is a trauma surgeon in Cincinnati, deployed about 7 times. He's in Afghanistan right now. And when he first started going on deployments 15 years ago, he would tell troops, I'm going to try and make sure I got you everything as though you were at home. And what he now tells people at home is, I'm going to try and make sure I get you everything as though you were wounded in theater. That's how far we've come. Yeah. But that in part because of the repetitions that we've had. Now, it's not like we want to have wounded. We get that. But we want to have that skill set maintained. And the survivability rate has been phenomenal at about 90%. You talked about obstetrics, and I want to point out what they do at Fort Drum, for example. You do have an OBGYN or two that work out of the clinic, but when it comes time to delivery, that provider goes to the local hospital to deliver for those troops and their family. And that's kind of a win-win situation. And those are more type of engagements that we may need to have as we move forward. But going back to downrange, I was very lucky when I deployed, because our general surgeons came from Detroit, New York, and Philadelphia, and they worked at level 1 trauma centers. My OR team came from New York, and every one of them had experience at trauma centers and were up to the task of this mission right away. The challenge we face is you may have a young, active duty general surgeon who's serving on a post where the speed limit is 15 and there isn't a lot of trauma. And so our goal is to get more opportunities for that surgeon to be engaged in the type of scenarios that they maybe need to engage in when they go downrange.
There's something else. Oh, go ahead, Admiral, please.
Thank you.
Sorry.
If I could just respond to a couple of things, because I think there's some really great points here. I couldn't agree more that we need the repetition. And I think that's one of the benefits, of the NDAA 2017, because what that allows us to do, Congress allowed us to set up these centers of excellence where we could concentrate our assets, our resources, our providers, and also be able to offer that care not only to the military, but the civilians, and create those military-civilian partnerships, as well as with the VA, so that we can get those patients in, we can get those reps. You know, to draw an analogy with aviation, our military treatment facilities, our hospitals are like our runways. That's where we get our landings and our takeoffs for our reps. So I think, again, with the authorities that Congress has given the Defense Health Agency, we have that opportunity now of creating centers of excellence where we can bring in that type of care, that complexity of care. I'd like to point out too, the effort of teams is extremely important, and the high survivability, and it's actually over 95%. If we had wounded that arrived with a pulse to any kind of forward resuscitation station, they had a 95% chance of survival. That's unprecedented. But we have to move away from using that particular outcome as our only internal management control. We actually have to explore what it would take for us to flex into the future to know how we could replicate that. And teams is an extremely important part of that, which is why what you'll see is that through the DHA, we're trying to integrate care with our patients, understanding what they need, integrating care across the services, and then integrating our care with the purchase care so that there's a more seamless experience of care. And in those teams that we talk about, our best survival occurs because we've got standardized uniform training for our corpsmen, our med techs, and our medics, that they all train in San Antonio at the Medical Education Training Campus, where they all know how to do resuscitative maneuvers in taking care of the wounded warrior. And I think that's actually been the largest part of our ability to create that high level of survivability. And I'm very familiar with the studies, and I couldn't agree more that we have to be able to invest in what we're going to see downrange. But I think it's also important to give you visibility that when you're looking at something like OBGYN, which has tremendous impact on our family members, which is also, I feel, a readiness aspect that we want to keep in mind. What you sometimes don't see are the second and third order consequences of the training opportunities that delivering babies or being in the GYN surgery, what that offers to our anesthesiologists, our nurses, our OR nurses, and our corpsmen and our techs within the operating room. So we don't want to lose sight, because that is an important part of the team. The team is not just the surgeons, not just the doctors. It includes the nurses and the techs. And then finally, to Orie's comment about interoperability, I think that is so key, that we need to be able to share that kind of data in such a way that we're talking about the continuum of care for our patients. But I think if I could take a slightly additional perspective and frame that within the national security prism, we need to be able to do that interoperability very safely, because we have found that medical information is becoming the Bitcoin for others to use in harmful ways. And so our ability to be interoperable with each other and the civilian and commercial space has to be predicated on how well we keep that information safe.
Dov, you wanted to follow up on?
Yeah, I mean, I don't disagree with anything you just said. My concern is, how far have we come? And I don't think we've come anywhere near far enough. Let me give you an example. Actually, the Congressman gave a great example. He lucked out, or his friend lucked out, New York and so on. What about those other 47 states that were not mentioned? There are no common standards. In fact, one of the things that really blew me away was we asked in the commission whether there is something uniform about what are called essential medical capabilities, which is really a readiness measure. And we were told that every military treatment facility considers that everything they do there is an essential capability. Now, I'm sure hoping that you're going to change that.
That was before the Defense Health Agency was stood up.
But it needs to be changed.
You're right.
And
No,
not
I
only
agree.
that, the mentality of commanders needs to be changed. Because one of the things, DHA is essentially, on the one hand, back office management, and on the other hand, policy guidance. But the implementation is still
You're right.
down the chain. And down the chain, it is not at all clear, and study after study has shown this, that there is enough appreciation of the priority that needs to be given to this. And it's not just a money priority, it's a mentality priority. And I see you're agreeing with me. So we have a ways to go here, because again, this is absolutely critical. Yes, it's true that the team will benefit from obstetrics, of course, but I would much rather have them benefit from true trauma surgery. They could go to a civilian hospital for the obstetrics. And one final point. We had a couple of major accidents in the last year and a half or so. One off a ship where 8 people were hurt. Only the most uncomplicated surgeries went to medical facilities. 6 out of the 8 didn't. They went to civilians. We had a Marine accident, 15. Virtually none of them went to military facilities. That tells me something. There is still something missing here. And I sure hope that under your leadership, DHA will keep working on that.
Orie, what can organizations like yours do to help close this gap that Dove is talking about?
As part of our responsibility to the Admiral and to the DHA is that we're accountable for helping them maximize the bricks and mortar. And so if you've got skills in there that you don't have the support staff in order to make the schedule run, we're required to bring people in and execute that team so that we can put more work back into there and so they can keep the skills going. So it's called MTF optimization, and we work very hard at that. At the high point, we have 500 or 600 folks embedded inside the MTFs to help either with surgery skills or with any type of medical skill, but also the technicians that help run the system to make sure that the throughput can get through the facility. So we work very closely with the Admiral's team to make sure we understand where those gaps are, because we look at each MTF and look at the work that's going on, and then what's the work that's going out to the community, and how can we put that work back inside the MTF. So we work very hard at understanding that and how to maximize.
Could I just wanted, because I think there's an important part here too. I completely agree with you, and I think part of what we need to do is we need to be able to commit ourselves to optimizing where we've got our investments. We also have to be able to make some of the hard decisions, tough decisions about whether or not we need to maintain certain infrastructure and at what expense. But I do want to also offer, we've been able to actually provide the rest of the American healthcare system with some very innovative and forward-leaning solution sets that have not been available to the general public, such as being able to help take care of some of the Boston Marathon bombing victims. We were able to do that at Walter Reed, and certainly in San Antonio, where we have our only DoD Level 1 trauma center. And I know the NDAA gives me an opportunity to establish more, but there we were able to help take care of some of the casualties, the mass casualties from Sutherland Springs. And so I think that being able to partner with the American College of Surgeons and other civilian trauma centers, we also can help contribute to that body of knowledge and expertise. So I think where we need to move towards is more bi-directional sharing so that we can elevate all of our collective performance in that. And I think that based on the recommendations from the MICRMIC, the authorities, and the umbrella of opportunities given through Congress, and certainly as I listen to our senior leaders in the defense, I think that's where we need to move to, and I think that's definitely the opportunity that we have at hand.
Congressman, Orie talked about the 3 kind of channels of healthcare provision that the federal government does, and you have insight into the VA system. Mm-hmm. I think most of the people here probably understand the interaction that's going on with the electronic health record system, but I wonder what you have seen in your oversight role on the Veterans Affairs Committee about the potential for interactivity and sharing services and sharing information and sharing knowledge between the VA system and Admiral Bono's system.
Well, I can speak to that on a couple of fronts. As far as electronic information, that is huge. Basically when I came back from deployment, I got my DD-214, my service record. They said, you should probably call the VA and get signed up. And when it comes to health record, where is it, who's got it, this and that, we're going to have the opportunity to just hit send, and your record is now at the VA. And that interoperability is important. And I think where we are coming together in that is that we are recognizing, when you make that commitment to serve your country, that's for life. And that carries right over to the VA. There should not be this wall that has previously existed, and that is coming down. We're seeing that come down. At Walter Reed, as I'm seeing now, I'm seeing veterans. When I go and we go through cases that came in overnight, the next morning, we're seeing veterans, and often more challenging cases than what you would normally have from your healthy members of the military, right? These are pluses, and these are the bridges that are being built between these agencies. A couple other things to comment on about training. Obviously, San Antonio Medical Center is a great asset to the military. Formerly was Brooke Army, now it's got all the services there. And you look at teams like our critical care air transport teams in the Air Force. We have the training for that at the University of Cincinnati. They're embedded there, and there's a simulator. And let me tell you, it is one tough course. And you are a team, right? You have your doc, you have your nurse, and you have your respiratory therapist. In that environment, people are sweating. You're talking through the headphones, and you can't hear buzzers go off. So you got to be watching your monitors. And many people don't pass. You don't pass, you don't deploy. Mm-hmm. So that's one of the shining stars. There's many shining stars. There are problems. I remember when I was deployed, I had a young sergeant complaining about something, and I said, Sergeant, just remember, you're in the Army that wins wars. So although we got problems, we address them and we try to make them better. And I think as healthcare providers, that's what we're always after. We're always looking for a better way, for a new innovation, for a new way to bring things together, to make the care better and to be better providers. And so out of every problem, there's an opportunity. So that's what I appreciate about this conversation too, is it is an opportunity to say, well, where can we be better? And we're facing it head on, and nobody's pretending that it can't be better. We recognize the good things we have and how we can make other things better.
So Orie, he gets to write the question that I was going to come to you for, which is where are the opportunities for VHA and DHA to work together and even bring CMS into this, to work together or on some level to make things better?
Well, if you think about the awesome capabilities that exist in the MHS and in VA, and there are excellent care being done. Some of it's duplicative, right? Mm-hmm. And we as taxpayers are funding both streams, right? So how can we understand and leverage the capabilities of both systems to the maximum? How can we not duplicate that stuff? How can we share? And you talk about training and all that. Flip and flopping, right? How can we when people get deployed, you got VA docs, how can we put them into the MHS and vice versa when the demand, porpoises on us over time? And I think that's an excellent opportunity. This eligibility stuff that goes on, within the different systems has got to be looked at. I mean, it's just incredibly complex. And you think of as a caregiver, when you're taking care of that wounded person or your soulmate, and trying to navigate through those three structures, because care is supposed to be given here, part of it here, maybe part of it over here. Way too complex in the time when the emotions are just going off the edge. And how can we simplify the process? How can we simplify the eligibility? How can we share resources appropriately? And how can we exchange data in a way that the Admiral's right? It's a huge asset, and one that people outside of our sphere would probably like to have in order for national security. So how do we protect that, but how do we create this environment where we can really share the resources, the expertise in these different lanes, and really be able to maximize that for our beneficiaries and for our taxpayers?
So Dov, Orie's comments make me think that there are two problems as far as breaking these silos. One is the provision of the care, and he talked about that a little bit. The other is the way the care is paid for and who pays for it. Admiral Bono is working through TRICARE, is working with people like Orie and also providing the care inside her service. VA service is almost entirely provided by Department of Veterans Affairs employees, and then Medicare obviously is essentially a fee for service. Is there a restructuring here that makes sense to get to what Orie's talking about, or does the way that the care is paid for not matter?
Well, of course it matters. It matters to the families.
Well, I mean, as far as maximizing the collaboration, though, among the three.
Yeah, absolutely. First of all, I do think that VA and DOD are moving closer together than they were in the past. I think they've made tremendous progress on the formularies issue, for example. And just to be clear what that is for those who don't, you could get a certain medication when you're in DOD, and then you retire and you go to the VA and they tell you, well, it's not on our list. And that is especially a problem for people with PTSD. Pete Corelli, General Pete Corelli, who is very active in this sphere, was a member of our commission, and he would talk about the tragic consequences of people who all of a sudden couldn't get the right medication. Stuff like that has to be coordinated much better. Of course, you've got to make sure that the money is there. One of the ways they've been doing it, of course, is under the new congressionally mandated structure where you now only have essentially 2 forms of TRICARE instead of 3. People are paying more. A lot of people are unhappy about that, but there hadn't been increases in over a decade. So that's one way to help out. Another thing is a lot of people say, well, you know, we're paying too much for health. I don't think you pay too much for health. If you don't have health, what do you have? And so the numbers aren't even that great. I said this before. I'll give you an example. One of the things we recommended was to actually have a new 4-star in charge of all of this. Now that wasn't accepted, but it turned out that the additional cost of doing that and some of the other things I mentioned was about $300 million a year. Now, that's money, but it's actually pretty much a rounding error for a comptroller, quite frankly. But if you take out setting up a new 4-star command, it's a lot less. So now what are you talking about? How much money are you really talking about to save those extra lives? We also recommended actually totally upending TRICARE and moving to the civil service system, which would have saved billions. But at least what they're doing is rationalizing TRICARE. And so money is being saved. And I remember when we set up the commission, everybody on the Hill said, oh, you're going to find us ways to save money. That's not really what the primary purpose is. If you do it right and you're more efficient, you will save money. But that should be a secondary consequence, quite frankly. The first thing is to make sure that families have the health. They don't have to wait forever to see a doctor, which you're making progress on. The doctors are willing to accept the families, which is another issue. And again, in the battlefield, people are being treated the right way for their traumas with a much higher percentage of success. To me, that's the primary goal.
Orie, and
Yeah,
then
can I
Admiral.
add a little color about some opportunities? We've done business in the DoD for a long time, and we've done business in the VA. And when I step back and try to think about the models, they look almost identical, because you have MTFs that have a certain kind of capability, and they need a partner to build the access around what they can't do. When I think about the VA, it's a very similar model, in that they have the bricks and mortar, and they have certain capabilities, and they have to buy certain care. And the models look almost identical from an operational perspective. Is there opportunities there that you don't have 2 different competing components, and maybe, gosh, we have one? And I know there's some conversations and chatter going on about that today, but how do we advance that discussion and get to the data and figure out if it's doable? So I think there's a grand opportunity there.
Congressman, I want to hear what you think about that, but Admiral, you wanted to make a point.
I do, because I think Orie's absolutely correct. I mean, do we have an opportunity here to look at how we're organizing and procuring that care with both DoD and the VA? But I think there's also an additional opportunity we have here, and that is look at how we go about delivering and creating value in that care. And one of the things that Orie and I have spoken about, which is our procurement process and how we moved to this relationship and how we go about being more compulsive and more rigorous in our upside and downside risk sharing. Because I think that then gets to what Mr. Zakheim was talking about too, in terms of there is a cost equation that needs to be considered in here, but it needs to be in support of the priority of the access, the quality of care, definitely the readiness at all times. But there does need to be efforts in managing that cost. So I think that what Orie brings up is there an opportunity for us to look at the model that we use in our procurement of healthcare and share that model with the VA, and at the same time as we're looking at that model, can we explore different ways of sharing risk and creating value? And I think that's something that that is a lesson that we need to bring in from industry into the military health system.
Dove, I'll come to you in just a second, but Congressman, I hear rice bowls being broken here that culturally in the Pentagon and in VA will be not easy to overcome.
Well, it is tough to overcome because each has separate budgets, and so it becomes, how are we paying for this? You know, how are we paying for the care of the veteran going to Walter Reed? And so I'll leave that to the accountants to try and figure that out. And if you need help from Congress, we'll try and make that happen. But that's the challenge. And at the same time, we're seeing things like we call IDES, interdisciplinary evaluation system. You know, it used to be if you were being medically discharged from the military, your disability was rated, you were evaluated, and then you go to the VA and it starts all over again. And now that's being done in a joint fashion more and more. These are things that make sense, right? And again, the wall coming down more and more. If I can just go off for a second, because I see Gary Sinise here, and I just want to thank him for all that you have done for our troops and for our veterans. And one of the few people in Iraq and Afghanistan, you know, a lot of people fly to the green zone, you know, these Hollywood people go to the green zone, say hello, and we appreciate that. He puts on the jacket and he goes down range, and you've done that for over 15 years now, and I thank you very much. So what I want to address is something that you have probably seen, and this is another wall that we can break down. Serving on VA Health, and I see my ranking member here, Julia Brownlee, I'm glad to see you here. The VA has to be reactive to so many of the problems that our troops face. I came home at 47 years old, able to go right back to my practice, and they said, well, you got 90 days before you have to go back to work. Well, I'm sorry, I'm not going to sit around my house for 90 days. This is the wrong answer. You go from being completely necessary to just sitting around your house. Wrong answer. And that's why I think we have so many people with problems, and now it's on the VA side. We need to do more before people take off that uniform to make sure that they have somewhere to go, to make sure that they have a purpose in life, that they are going to leave here and be necessary just as they were in the military. And I think we're going to save a lot of adversarial things that happen to troops when they leave the military. One more opportunity for the walls to come down. And so any help we can get on that conversation, ma'am, to do more on the DOD side so that be proactive.
Sure.
You know, we love prevention, right? Mm-hmm. Prevention doesn't get much attention. It's not sexy like surgery is. Mm-hmm. But we need to do it, and that's just one more component that we can do. That's again, another opportunity for the two entities to really come together and make a difference for our troops.
I agree.
Dove?
Well, I was just going to say that, you know, in any kind of merger or acquisition, it takes time to merge cultures. Sometimes it can take years. And so I think the way they're going about breaking down those walls is probably right. If you go too fast, the whole thing's going to collapse because the cultures are so totally different. But where the culture can be forced is inside DOD. And, you know, personally, I still don't understand why we need 3 separate Surgeon Generals. Congress didn't buy into that idea. I don't need to debate it now, but the point is we still have too many different medical cultures inside the department. They're not fighting differently, they're being hurt the same way. It's very, very different. And it seems to me that one of the challenges for you, Admiral, is exactly that. How do you break down the internal cultures? Yes, let's work on improving what's going on between DOD and the VA, but let's tend to our own garden first.
Admiral, the conversation a couple minutes ago went to something, and I'm looking at the title on my notes here of our panel, and I'm reminded of something that you said the last time you were on my program, which is that we should not just think of the DHA and TRICARE as a benefit. And I wonder if you could expand on that a little bit in the context of this topic. Are we providing a benefit worthy of the sacrifice? What you mean by that, and how maybe we should change the thinking of the way we're looking at this.
Thanks, Francis. We definitely need to change the thinking on this. This is more than a benefit. While we have a clear operational role in the military and being able to be there at the point of injury and make sure that we are able to bring people back home and then be able to take care of them through their recovery and get them back to mainstreaming them into their lives so they can resume their lives and their career. That's something that's very visible, and that's something that we're all committed to. But I think we also need to expand our thinking about what the military health system can do in terms of a strategic way of looking at what we offer in terms of the readiness and the prevention that the Congressman mentioned. So much is saved by being able to do the upfront, upstream things. And the part about that we can do contributes directly to our ability to support the national security strategy. Our ability then to return people as quickly as possible to the fight is another aspect of that direct impact that the military health system has on that. But I think there's another piece about this that we can contribute to the overall modernization of the military by being better stewards of how we use our sunk costs, our infrastructure, and our investments, and being able to take that longer term view about how to get there. And then, you know, the other part of that in being able to do that is how well we can not only create this system from within the military health system, but I believe that what we're doing in the military health system can also inform some of the challenges, the solutions for some of the challenges that we have in our national healthcare system. And that's actually the part that the military health system has as an advantage over the commercial and private space, is that our patients start out with us. They belong to us. We also own the healthcare plan, and we also have direct oversight and control, for the most part, the providers. So we've got the three main stools three main legs of the stools for health care. And I think that while we do this, and I couldn't agree with you more, we need to do that from within DoD first before we can actually partner effectively with anybody else. But I think in the same process, we can provide lessons for the national health care effort in addressing some of those challenges.
Orie?
Yeah, I think the DoD is sitting in a very unique position that many companies in this country would love to have, and that's the data. When you think about the MHS, sometimes you've got people from birth to expiration, and everything in between. And the understanding of that data and being able to grind it and understand the characteristics of what causes conditions to come on and how do you prevent them, that kind of thing is just, it's mind-boggling what the opportunities could be, you know, with that data and the analytics around it, and what we could do to not just improve the MHS, but also improve medicine globally. You know, it's just such a great resource and asset. How do we leverage that to the maximum?
So, Congressman, we've talked a lot about, so far, the place that the military healthcare system has within the military, and what Orie's getting at, I think, may be something that we've missed, which is what part does the military healthcare system play in the broader healthcare system of the United States, and what is the opportunity for interaction and interoperability, not just among the other government healthcare providers, but and not just the contractors that deal directly with TRICARE and the system itself, but just sharing information and sharing data and sharing knowledge.
Well, yeah, you talk about data and bringing that together, and lessons learned lead to best practices. Yeah. And let's face it, so many things that have been learned for all of medicine have come out of the military experience. Mm-hmm. And this is just one more, but now you're not only talking about what you're doing downrange, but what you are doing in garrison, et cetera. And so the ability to bring a lot of data together. What make it even better is if you are treating veterans, because you know, if you're in retirees, so you have a broader age range and a broader range of illnesses, if you will. You know, when you're downrange and you're taking care of troops, I mean, they're not diabetic, they're not this or that, they don't have a lot of medical problems except for what just happened to them traumatically. So if we expand the scope of that even more to gather more data, then we can have a greater impact. Yeah. I do want to say I disagree a little bit about the Surgeons General, and here's why. When you're at a place like Bagram or Balad or in Garrison, Walter Reed, I don't think it matters. But when you're talking about things that are specific to the operations of that branch, you still speak a different language. You know, I don't think you could just throw an Army person immediately into the critical care transport team necessarily. You can't just get aboard USS Comfort and be able to speak the language. And what an Army cache does is unique to itself and speaks the same language. So I still think there's a need to have this separation for some of the operational things that are clearly within that service realm.
But we haven't actually done that either, okay? If you made the Army the executive agent for all the land hospitals, Landstuhl, and you made the Navy executive agent for the hospital ships, and you made the Air Force executive agent for getting people out, I'll buy it. It's not what's going on right now.
Good point to be made.
No, I'm gonna have to. I'm like sitting right between here.
Just duck, Admiral.
But you have the ability to disembowel both of them.
I know, exactly. More practice.
Oh my
you're
God,
about
you're going to
to.
be so busy
I'm very
disemboweling. You'll be very
No,
proficient.
I will be very proficient. But here's some additional thoughts to this, because I think we have to look at, we're a microcosm of the rest of DOD, and DOD is not going in as a single service anymore. And as a matter of fact, our ability to have the type of survivability rate that we had in the last 15 years of war occurred because all the services worked together. Mm-hmm. It didn't happen because it was, just strictly a ground campaign. We had to rely on all domains. As the chairman of the Joint Chiefs talks about, we're always going to be multi-domain, multifunctional, and it's got to be multi-service. And so I think the ability that we have of working across each of the services enables us to be more effective no matter what the domain is, no matter what the campaign. And while there are some nuances, like in the Navy we call it a bulkhead, and apparently the Army calls it a wall. Those are things.
Is it a beautiful bulkhead?
It's a beautiful bulkhead. I will say this about medical. I am board certified by the American Board of Surgery, not by the Navy Board of Surgery. And my fellow surgeons in the Army are not board certified by the Army Board of Surgery. So I think you have to look at medical through a slightly different prism, and that is that our standards for performance are dictated or are governed by outside entities that go across all the services. So I think that that's something that we need to make sure that we're optimizing, because we could actually capitalize on bringing the services together. And I know there's a lot of emotion when you talk about what the Surgeons General do and everything like that, but I think we want to be very mindful and thoughtful about the fact that some of those nuances aren't necessarily impactful to the actual delivery of health services and health service support.
You just made a much better argument for my argument than I did.
Thank you.
But you're ruining the Army-Navy game.
No, I'm still, go Navy. Army's got a good team this year, though.
Can I make a supplemental point?
Sure, Doug.
We talked a little bit about TRICARE, and the point was rightly made about its impact on national security. There's another impact. Because anybody in the field can now speak to home on a cell phone or whatever, if you're not getting the right care at home, if your wife, children, husband, whatever, loved ones is not getting the right care, you're not going to perform well in the field. It's going to have a huge impact on morale. And I don't know that we have focused enough on that connection. We talk about the kind of care, the speed of care, the cost of care, co-pays and all the rest. But there is this fundamental fact. We are not the military of 25 years ago. We're a military, when we were on the commission, it hit us with a 2x4 just to what extent we're not talking about a bunch of single young guys in the military. This is a family business. The families are involved, and if your kid was up all night and your spouse could not bring that kid to a doctor because the doctor wasn't available because TRICARE let them down, it's going to affect how you operate in the field. And I think we need to focus a lot more on that.
Orie, how can you and your colleagues help, Dove's point there, help the warfighters feel more comfortable and confident about the care that their families are getting at home?
Family resiliency is very, very important, because to the points that I've made. In the commercial industry now, people are really turning away from, sitting back here, I call it with the catcher's mitt, waiting for people to get hurt and injured. It's more now, let's moving dollars and programs up front and focusing on wellness and well-being. And what does that mean? And it means a lot of different things to a lot of different people, but it's about, maximizing your best health. And how do you do that? As opposed to, I say, catching people coming down the curve when you really have less opportunity to be impactful. So how do we focus more on the family unit? How do we engage? And there's lots of new technologies and new things that are coming out that bring the family closer together. They compete against each other with these things, right? And the challenges and all that stuff, and it gets people up and moving and get going around and doing things, as opposed to being sedentary, sitting here when the children have the opportunity to sit here and play the games all day long. How do we get people moving, and how do we get them active? And I think focusing more on that, as opposed to trauma care, specialty care, how can we prevent that care from being needed? And so focusing on the front end of the system now is really the focus of the actuaries, and everybody have finally figured this game out, that you sit back here and wait with all the actuarial tables, you're going to get hurt. Let's move stuff up front. So
that's exactly what you talked about a moment ago about prevention.
That's right. And General Horoho, previous Surgeon General of the Army, she used an expression that I've used over and over and over again. Every one of us has a lifespan, and none of us are getting out of here alive. How do we increase the health span? Right? How do we increase?
I hope we get out of this conference.
Well, we'll do that. We'll do that.
I didn't think I was doing that bad of it.
But we shorten that time, right? How do we keep people healthier longer? And this is an area where the military can lead the way as an example to America, because we can have greater access to preventive care, because it is right there, and we can focus on those things. I have a one-block cartoon that has been in my head for 25 years, and I finally had someone draw it up, a comic, if you will, and it's got somebody overweight, smoking a cigarette, drinking a beer, and a donut in the other hand. And he's watching his friend change the oil in his car. And he says to his friend, "I wouldn't put that crummy oil in my car." Right? But he'll do all these other things to himself.
Absolutely.
That's what we have to focus on. We will save tremendously, and I think we can lead the way on that, and I appreciate that input.
I did not note at the beginning of our conversation that we are taking questions through the app at rndf2017.org, and the Q&A will begin shortly. In the time that I have left, I want to just kind of go down the line, traditional panel style, and just, oh, terrific, thank you very much. I just want to get thoughts, topics, comments, follow-ons that we didn't have a chance to ask directly, and give each of you an opportunity to add on to anything that's been said so far before I go to what's here. Start with you, Congressman.
Just one thing that's kind of been on my mind because of recent disasters. And we look at Puerto Rico. Puerto Rico was already having a problem with health care because many of their doctors were leaving the island. And so they have a doctor shortage. And now we have this disaster, so it's very evident the healthcare problems that exist there, unfortunately. What an opportunity for us, I think, as a military to be there permanently and establish something like San Antonio. And that would be a win-win for everyone. And you can also have your reservists rotate through there doing their active duty time. And that's just something I wanted to throw out as an idea while I've got the head of DHA right here.
Conveniently located.
Noted.
Ma'am?
Well, thank you again. I think that we've got a great opportunity here to create something that hasn't been seen yet, and that I think for the military beneficiary, we have the best patients in the entire world. We have the most deserving patients in the entire world. And so the opportunity that we have in our military health system, with all the support from Congress, the support from our senior leaders, the great ideas, the innovation, the thoughtfulness, the challenges that you're presenting to us, I think only give us the opportunity to really elevate our game and create that healthcare system, that integrated system of readiness and health that our beneficiaries so richly deserve. And I think that when I'm listening to you describe about the impact on readiness, it reminds me, though, that this is what happens to everybody else outside the military. Everybody has some kind of concern about some kind of health, whether it's their own or somebody in their family, and whether they have access to that care and can continue to perform at a high level. And I know this is probably another panel discussion, but I think that really is that's the underpinning of anybody's stability and security and economy is that prevention, that health, that access to that care. I think that the opportunity we have in the military health system is to create that model, and I'm just very excited and very appreciative of the opportunity that I have. Thank you.
Dov?
Well, we've talked quite a bit about how the military has a lot to offer to the civilian world. And one thing we haven't really talked about, we talked about DOD and VA. What about DOD and HHS? It seems to me that if we did a lot more on the HHS side, we being DOD, there would really be an opportunity to cross-pollinate, pick up best practices that the military offers, and you've heard a lot about those today, best practices in the civilian world, because they truly are symbiotic. And so if we had a lot more time, I would have hoped we could talk about that, and maybe this is something we can think about in the future.
Excellent. Thanks, Dov. Orie?
Yeah, I'd like to just add a little color to the Admiral's comments around the procurement process. When you look at how DOD procures, their support partners, it's a long process. And the risk sharing, I think, is something we need to accelerate, because that creates the opportunities for investments from our side to be able to test, fail, learn, adjust, test, get better. But today's contractual structures really don't add that space for risk sharing and for investments and for improving outcomes and that kind of stuff. So if we can move that quicker, I think it would help, as opposed to, I'll tell the Admiral, I appreciate what they've done in this go around, because the last time it felt like whack-a-mole. We were kind of sitting on the side, and they were looking for you to make a mistake. But this time, the partnerships are strong, the transparency is good, but we need to still take the contracting to another level. And I think we need to work on that as we think about the next one. We only have 20 working days until we install the new contracts, and we're all focused on that. It's, how do we prepare for the next one?
All right, questions from the audience, and I will remind you, my friends here on the panel, that because they're questions from the audience, I'm just reading them, not writing them. So,
Admiral, are you ready?
It's somebody out there's fault.
That's what you're telling us.
That's exactly what I'm telling you. First one, as a military retiree, I feel that TRICARE benefits are not worthy of the sacrifices made by military members and their families. COLA increases negligible at best, copays and enrollment fees continually increase. What are you doing to correct these trends? Who would like to take that one? Admiral, you're very brave. Go.
I appreciate that point of view from the retirees, and I think that this is one of the things that we're trying to do through the Defense Health Agency, is that the health care plan belongs to the beneficiaries. Our TRICARE, our retirees, our active duty, and the family members. And so being able to be responsive to those needs is extremely important. And I think that's probably the first point of integration that we're trying to create in the Defense Health Agency, is how can we integrate our healthcare system with the patient, and how do we design that around their needs and values. I do know that there's some concern about copays and the increase in that and the cost shares. And I've been very transparent in trying to share how we've come up with some of those calculations. But I think it's also important that as I'm comparing our performance to industry, it's also important for our beneficiaries to know what we offer compared to industry. And so while we do have some increase to those pays, and this is, I dislike saying this because it's not a justification, but our increases have been relatively modest. I think the onus, however, is on the Defense Health Agency to still create and find more of those efficiencies so that we can do the bulk of our modernization through that. But the benefit has expanded and will continue to expand. And in order to be able to offer that to the broadest number of beneficiaries, we do need to have some fiscal transactions in there that allow us to continue that pace. But what I can promise is that we will make it as extremely responsive as we can to the patient's needs.
Well, from the congressional standpoint, as especially someone who's approaching 20 years in service, it has been difficult. It has been difficult to try and make sure that you can extend benefit and do it affordably. There's no doubt about it. Money, funding plays a part in it.
Does.
Sometimes there's a change in copay so that we can pay for another benefit that is existing out there. I'm not going to sugarcoat it. And I agree with the Admiral where it does pain you to say it, and it's not necessarily a feel good, but it is still better than what has happened on the other front.
Right.
I actually look forward to the opportunity to be in TRICARE as opposed to what I have today. Doesn't make it right, doesn't necessarily make you feel any better. That's some of the realities and the challenges that we face, but I guarantee you that the effort is going to be made always to try and minimize that negative effect and find other ways to maximize accessibility and availability of care.
Right.
Question for Dove. Admiral Bono advocates bidirectional sharing of medical knowledge and experience. Is that contrary to what you believe about the gap in military medicine? Should we use our private partners more or learn to do it all ourselves?
No, I don't think we can do it all ourselves, and I don't think we should do it all ourselves. We've talked about cross-pollination because clearly if your surgeons are training 100 times a year and you need to train 5 times more than that, the only way you're going to do that is by going outside the MTF system. Now, there are big efforts to bring people in, but even so, that's not going to get you up to the 500 standard, which I think you would agree is really what you want. And so you have to cross-pollinate. There's no other way. But as you do that, it's important to bear in mind why you're doing it. And the objective has to be to save as many people as possible out in the field. That has to be the primary objective. I know why you would argue for obstetrics. I'm not saying they shouldn't do any of it or anything like that. But that is not the fundamental objective.
Mm-hmm. Orie?
When I think about this need to be able to keep the skills to the level they need, I remember back in our Humana hospital days when we talked about taking care of trauma 1 and indigent care and how that's a local problem from a funding perspective. And so is there an opportunity here to think about a win-win, right? That we get into every major metropolitan area needs these skills because of the things that are going on in the world today, right? I know my wife was a trauma 1 nurse for a while, and it was scary. When she come home and share the stories about what she took care of tonight, it's like, you need to get out, you need to get in a cardiac, or you need to get something a little bit more clean. But this seems like a win-to-win, that if we really put our heads around this and think about where the community needs are, where the military needs are, match this up, and we may solve 2 problems, right? Mm-hmm. So something I think we need to explore and think about.
Admiral, how do you manage something like that to make sure that the right people are going the right places and then that your people are getting the right experiences that they need?
Really great question. I think that's where it is very important to be able to work with the services, because the services still retain the responsibility to recruit, organize, train, and equip. And so by working with the services and understanding what their training needs are, then we can get the military people in the right places. I think what Orie is also describing, though, is the better we can partner with him and with other civilian institutions allows us to create those training opportunities.
Do you have the infrastructure set up the way that you need it to be able to do those kind of communications now, do you think?
We have a large part of that infrastructure set up. We still need to do some additional work. So between now and October 1st, 2018, when we will actually go live with a lot more of this integration, we're building that infrastructure and those processes now.
What about the people that are ready to be able to do that? Are they in the right spots?
Not yet, but I think the nice thing is that while they're not in the right spots yet, we have the right people out there, and I think that's the more important piece. And working with the services, we can bring them into this collective effort and then create that product.
Does that all make sense to you, both from a care provider perspective and from a congressional perspective, Congressman?
It does.
Last question for Admiral Bono. From the perspective of a service member, the most frustrating part of healthcare is gaining in-garrison access to care. How are we fixing, I won't use the term that's on the question, how are we fixing that and getting daily care to service members, ma'am?
Yeah, it's a great question, and I think that's one of the things that I'm very excited about, is that we're actually expanding that access, because one of the things that we realized is that while some of our metrics showed that our access was good. The feedback that I was getting from our patients was that it was too hard to get in. And so in that situation, what I believe we need to do is we need to reconcile that in favor of what our patients' perceptions are. And so we're expanding the hours that we have in our clinic. We also have access to urgent care centers that you can now go without prior authorization. We are also looking at other ways of partnering with our managed care support contractor. And one of the things that we're doing as a pilot is looking in the National Capital Region to understand where the demand signals are coming from and being able to set up outpatient clinics in those areas. So going to where the patients are. Mm-hmm. So hang in there, keep on letting us know what we can be doing better, because this is your healthcare plan.
Dov?
Yeah, I was just going to jump on the word metrics, because one of the things that I certainly found in all my dealings with DOD is we have metrics, they're not necessarily the right metrics. And I'll give you a concrete example. We've gone over in measuring how effective we are with our surgeon corps to a thing called KSA, knowledge, skill, and ability. We made a whole big fuss about it, and it looks like we're doing real well until you actually look at what's going on the ground, and it hasn't shifted at all. So the metrics, how we measure how well we're doing, needs to be really something that will allow you to progress, and not something that becomes a vehicle for essentially covering up what you're doing today. Mm-hmm. And I think that's a huge challenge for you.
Orie, we're almost out of time, but is that something also that maybe your private sector folks can help public sector, not just Admiral Bono and her colleagues, but at VHA and HHS, help with what should be measured to get the desired outcomes and not just to get good metrics?
Yeah, at Humana, what we're doing is we set a bold goal where we want to raise the health of all the communities in which we operate in. And they've gotten to the CDC Healthy Days measure, and which takes in all the different aspects around that. So there's a lot of good work going on, bringing all the community resources together to help, because there's a lot of people out there that want to help. It's just how do you make sure that that the organization is right, and and so they bring stuff together, create agendas, execute on, and then measure every year how the community is getting better through the Healthy Days, and it's an acceptable, tested metric that tells about the health in the population. So those are some ideas that we're bringing to the government to understand.
Congressman, we have about a minute and a half left, and I want to give you the last word. What did you hear among this entire discussion today that's something that you can take back to either HASC or HVAC and develop some new legislation or new policy, or just an issue that you can really dig into, you think?
Well, I think for me, sitting on the personnel subcommittee, it's building the relationships with the people that are here today, for one, and talking about what do you need from Congress to be able to make the changes to move forward, to make sure that we can implement things like the KSAs you talk about. Should we expand KSAs to more specialties than we're talking about? And so for me, it was good conversation. It was a lot of stuff that's been on my mind, has been on their minds. Learned a few things, took quite a few notes, and but be able to take that opportunity to build a relationship, and that I think is one of the greatest benefits that I think I got out of this today. And I want to thank you, and I want to thank everyone for being here, and especially this great panel.
Congressman, thank you. Admiral Bono, thank you very much. Dov and Orie, thank you as well. Thanks to the Reagan Foundation, thanks to the sponsors, and most of all, thanks to you for your attention today.